Light the room. Spread the fun. Lift a stranger. Express your soul. Walk head up. Live in happiness. It's all done with a smile. Smiles can change the world, and we're driven to change as many of them as we can all around it. NYU Dentistry is pioneering research in oral medicine, applying breakthrough methods of care and advancing the latest treatments, from the most common to the most complex, for the young, for the old, and for all in between, regardless of ability or disability. And with practices in Manhattan and Brooklyn, we're making our level of care more accessible to the communities we serve. We're determined to change the face of oral health everywhere, and we're driven to brighten lives one smile at a time.
So let me share with you some clinical indication to GTR techniques, and we'll like to develop and we consider some starting from basic concept, rational, and how this technique change over the years. So the first patient, Domenico, came to my attention in 1989. He was complaining about something was happening on his left central tooth. This tooth was bothering him because he felt something like in an uneasy situation. His referring dentist was telling him that was probably something happened due to funny episodes. Could be some changing weather, or something funny. Anyway, he was quite afraid to have this some problem on this tooth, and so came to my attention. I performed a periodontal evaluation, and as you can see over here, his gingival architecture is fine. He has a beautiful gingival architecture, nice stippling gingiva, nice orange tissue-like gingiva, and beautiful also papilla in between the two teeth. And normally when you have diastema, we are losing in papillary height. However, he is completely periodontally sound in every teeth except on this tooth, where he show some deep probing depth on the mesial aspect, approximately 10 millimeter, and also approximately 13 millimeter on the medial aspect. And now we start to see some bleeding, or some bleeding also on the previously inserted probe side. And so he is coming in a healthy situation on the distal aspect of this tooth. Also on the palatal aspect, he has a advanced compromised periodontal lesion on the mesial palatal aspect, as he had on the mesial buccal aspect. So, of course, our diagnosis is like a deep periodontal lesion, advanced periodontal lesion, localized periodontal lesion. And also, of course, during the first visit, we don't have to raise the flap to make a diagnosis, but during the treatment plan, we have the luxury to evaluate how this anatomical deformity, or these abnormalities of the root surface, was able to bring over time some etiological factor along the root structure, and he developed an advanced bone lesion. He developed advanced bone lesion on both sides, on the palatal side and also on the buccal side. So we have a localized periodontal lesion on this anterior tooth. So we make our diagnosis. We have to know that we have a disease, soft tissue, and bone destruction near the primary etiology. We have to clinically to diagnose. We have to perform our etiological phase. We remove the etiology from the root surface, and now we have to rely upon some structure. As pointed out by Giorgio previously, we have to rely on endosteum, periosteum, periodontal ligament as our defense mechanism. So these three structures that belongs to our periodontal component to periodontal anatomy they have the capacity to bring us or to furnish or to give us some mesenchymal undifferentiated totipotential cells. Now we call it stem cells. They are coming from the bloodstream, and these are the powerful to rebuild in a certain condition if they have some help, to reconstitute the lost periodontal attachment apparatus. So we can have some reattachment on the neighboring teeth. So because in order to make a flap access, we have to raise a flap. In order to treat this lesion, we have sometimes to make a flap that takes advantage of the neighboring teeth. So we don't have to instrument to touch the neighboring teeth because this tooth was healthy to start with. This tooth was healthy from a periodontal point of view, was healthy, so we don't have to touch these teeth in order to achieve at the end of our surgical procedure what has been reported in the literature or from a histologic point of view, a reattachment. So if we have a healthy structure over here, healthy periodontal structure over here, we can achieve at the end of our surgical procedure a reattachment because these structures are healthy, we leave it healthy, we don't touch it, and at the end we can have some connective tissue reattachment because they're healthy. But on the other side, on the previously diseased root surface, we have to instrument, we have to perform our etiologic therapy, we have to create the condition in order to get a new attachment. New attachment means the possibility, as been introduced previously by Giorgio, a new cementum first, new fibers, and of course also we hope also some new bone. So we have to think about the possibility with this approach that has been nice and previously described by Giorgio, as had been introduced in the literature in the early 80s, to get some new. Through this new technique, we can have a new attachment, something that was not expected before, because with this principle of the GTR, of the barrier membrane, we can take care in the best ideal situation of the blood clot. So we can modify, we can make advantage of this. So now, today, with the GBR, we can understand how powerful is this healing process. The beauty of this machine is like a Ferrari. So when you are young, you don't know how to drive this. But after many years, you understand the powerful of this technique. So after GBR, that we have the luxury to perform first a surgical procedure and also doing a re-entry, we were able to appreciate how it is possible to recreate new bone when we do not have any residual bony walls. And also now we can treat also perimplantitis type of lesion. We know also if we do not have any residual bony walls with this fantastic technique, with this, based on this biologic concept, we can achieve what was a dream in the past. And so we can create a bone in horizontal way, in a vertical way, and also we can treat any type of malposition type of implant, because this technique, the GTR technique, the basic principle, the biologic principle of guided tissue regeneration is a wonderful technique, is a wonderful principle that can be applied not only around teeth but also around the implants. So according to what Giorgio mentioned before, we have to start from a basic steps. So we have to classify our bony defects. So we are treating with the GTR some infrabony type of lesions, and it can be as classified by George in a 3 walls defect, like a crater or moat type of lesion. This is respond nicely to any regenerative type of procedure. Now we have a 2 bony lesion, considering the residual bony walls, and also sometimes we have also 1 wall bony lesion type of defect. This is the most challenging one, because as Giorgio pointed out before, we have only one sources of cells coming from only one residual wall. So, but anyway, the most clinical lesion reported in the literature, it is the crater that can be considered a 2-wall bony lesion, and what is clinically considered the most popular one probably is the combined lesion. Combined, it means that from this level down to the apical extent, we have a 3-wall bony lesion. From this level down to the apex, we have like a combination of 2-wall, 3-wall, and only the most apical part is a 1-wall bony lesion. So we have a combination, and this makes a quite a challenging situation, because over here the clinician can select the more appropriate filling material or the surgical approach that he can apply this type of lesion. But in order to make it once again it easier from a clinical point of view, I'd like to share with you the concept of a contained type of lesion or contained type of defect. It means that the majority of the lesion is still surrounded by the residual bony walls. And this concept can be applied also in implantology. So when we have all the majority of the threads completely surrounded by the residual bony wall, you can consider this a contained lesion. This lesion will respond nicely in a very nicely way to our regenerative procedure. So we have to pay. We have to make some effort, but this will be very favorable from an ideal result point of view. On the other side, we have this type of uncontained type of defects. It means we have only few residual bony walls, or let's say that the majority of the tooth structure is exposed, the majority of the implant thread have been exposed, and so this is a more challenging situation. So in this case, the clinician has to know very well different materials and different techniques, because this is quite demanding type of regenerative approach. And also in perimplantitis type of lesion, we can apply the same principle, the same concept, and we can consider that sometimes we have some contained type of lesion, and the approach could be easier. Sometimes uncontained type of lesion. So you can see that it's important to make a correct diagnosis, because the correct diagnosis after will give a direction in order to select the most appropriate surgical technique, and also the more appropriate material. In order to make a long story short, for example, if we have like in the around, considering for a few seconds the implant field, if we have a contained infrabony defect, it means the majority of the threads are still surrounded by the residual bony walls, and if our goal is to treat the infrabony component, probably only a bone filler or a bone, an autogenous bone or a barrier membrane or connective tissue graft can take care of this lesion, and the patient can go back to its normal function. But if we are facing, or if you are diagnosing a more advanced type of lesion, like uncontained type of defect, it means the majority of the thread have been already exposed to the oral cavity and they are infected. This is a more challenging situation. So in this case, the clinician should select a more challenging situation, a more challenging material. He should utilize a non-resorbable barrier membrane. He can utilize autogenous bone. In this case, a more indicated solution, it could be a submerged approach. So this makes the difference from a planning point of view, or also for the patient point of view, because this patient, he has to lose the function for a certain period of time. So in order to make a long story short, it's very important to make a good, strong diagnosis. We have always, in this case, to treat this case with a non-surgical therapy in order to reduce the amount of inflammatory process, in order to get to be ready for the surgical approach with a very sound, healthy tissue. And of course, the diagnosis of the defect is is playing a primary role on our material and technique selection. Once again, we have to make a clinical diagnosis considering contained type of lesion versus uncontained type of lesion. And also we have now a lot of regenerative options. Okay. Don't forget, the last but not the least, the maintenance therapy is extremely important, because these patients have been already previously exposed to periodontal inflammation. So now we have to take care of them. We have to follow them very, very nicely in a very accurate way. But the final decision, it's always, I remember when I was a student, the teacher of mine were telling me, what you do if this was in your own mouth. So many times we are not sure which type of material to select. We are not sure to save or extract the tooth. So in this case, probably many times we have to ask to ourselves what I will do if this was my own mouth, or my own teeth in my own mouth. So in order to make it clear, let's say now that we have a different solution. So starting from a historical point of view, this case is a case that's been given to me by Dr. Kramer. He treated this case in 1974. And he treated with the concept of 1974. Was a contained type of lesion. At that time, it was like a historical phase of periodontology treatment, and he had to collect at that time some autogenous bone with an orthopedic approach, removing bone from a different part of the body, not from the mouth. He had these carrots of bone. He split this carrot of bone and inserted this bone in this mesial aspect of this furcation involved tooth. And in this case, he made some measurements, and he filled at that time this defect with a part of this bone, and he followed this patient, and I had the luxury to probe this patient after approximately 10 years, when I was a student and I was working as a young doctor on his office. And I had the luxury to probe this patient after 10 years. So he had a good result. But he had a good result because, of course, he was a good clinician. He made a good selection considering the type of diagnosis. He made a good selection also according the material that in that period was available in the market. So now we'll switch from 80s to 90s. So now we have the concept of GTR. We can treat a more advanced type of patient, but once again, the patient come to our office. We have to make periodontal diagnosis. We start with a non-surgical approach. We start collecting, of course, the data from a periapical point of view, and now we have to prepare this patient from a surgical and eventually surgical approach. So now the patient, he had some reduction of inflammatory process. The tissue are much better now than before. We have comparative clinical pictures that are telling now that the patient now is ready, at least is ready for a surgical approach. At that time, it's almost 20 years ago, we make once again our diagnosis. We select the posterior sextant. As you can see over here, we have a deep probing depth. Still an inflammatory process is going on. We raise our flap. We make an intraoperative diagnosis. So we are lucky because it looks like a large, but it's a contained type of lesion. We are lucky. So our effort in order to regenerate this lesion it's important, yes, but we are lucky because we have some residual bony walls. But because it's large, it's quite, it's almost getting involved with the neighboring tooth, I decided to use in this case the barrier membrane because they were available. We are at the beginning of the resorbable barrier membrane. I try to protect the clot with this barrier membrane. I suture the flap in a more coronal position, and now we can follow this case after the following year. We made measurements because at that time we were evaluating the beauty of this non-resorbable barrier membrane, and so now we have the results after many years. So we had the possibility to do some re-entry procedure in this case in order to make a crown lengthening on the distal tooth. So we had some satisfactory result. The lesion, we didn't disappear completely. We have some residual infrabony component. However, it was much better considering the soft tissue quality how it was before and how it looks now. We don't have any more inflammatory process. There is no bleeding. There is no probing depth, and also the lesion made a lot of big improvement. However, now we can do some osteoresective surgery on the neighboring teeth in order to do crown lengthening, and we can make it as good as we can. And so we'll perform, in this case, we did some additional treatment to perform crown lengthening on the molar tooth. And so now the situation is very stable over time. So we treated later on, we treated also the maxillary right sextant with the same approach. Deep lesion, suppuration was coming out. We make our diagnosis. Same, more or less the same lesion. It was more advanced in the buccal side in this case. In this case, I utilized a combination of freeze-dried bone allograft first in order to fill the defect, and on top of this freeze-dried bone allograft, I place a resorbable barrier membrane. But we are still in the 90s, okay, with the technology that he knew at that time. So I coronally advanced the flap. And now we have the result. In this case, we appreciate some better results compared to the previous one. So in this case, I got almost what was I considering my ideal healing from a re-entry type of procedure. So I did this re-entry procedure because it was a part of a study, and so I could appreciate that this side did slightly better than the other side, the left side. So the combination of filling material plus resorbable membrane, it can give us probably a better improvement, something better than compared to in membrane alone. We consider that this filling material can give a better support to the a resorbable barrier membrane, a collagen resorbable barrier membrane that most of the time is a very soft material. So we need some stable, strong material underneath in order to hold this resorbable material, this soft material, in an ideal, better position, or the position that we'd like. So if we compare the previous lesion to the re-entry procedure, now we are quite satisfied about the result. And also this comparing the previous probing depth, and this is the comparative clinical picture. So also it seems very stable over time. Now we have 27 years of follow-up. It looks a very nice condition of the bone, and a nice, beautiful architecture, no probing depth, no bleeding, and so of course we got some recession out of this, but this is a posterior area, and it didn't jeopardize the aesthetic of this patient. And also the other side was doing pretty well. Of course, in this case, we did a smaller retouch, smaller re-entry to make a crown lengthening for this crown, but now we have a very stable condition. So this patient, we started the treatment in 91. Now we can follow him after more than 27 years, and it seems very stable over time. So now let's switch to Vincenzina. Vincenzina, she's a very, very nice patient. I met her in early 90s. She was concerning about some problem on this posterior molar and also on this posterior tooth. This had some discomfort when he was chewing, when he was brushing, especially this lower left molar was something was bothering her. So I make out my periodontal diagnosis starting from probing depth. It was almost, let's say, approximately 10 millimeters. We don't have any, only a reduced amount of keratinized tissue, and you have a periapical X-ray showing that you have some demineralization on the mesial aspect, also in the furca. So we are in the early 91. We have the knowledge of that period. At that period was available only the non-resorbable PTFA barrier membrane. And also the flap approach was something different that we can, we'd like to share later on with you, like a papilla preservation technique. But still, the most important step is our diagnosis. We plan our flap. At that time was like an open flap curettage type of approach. We didn't split the papilla at the base, like I will do it now. However, this is the type of lesion that I found at that time. So we have some residual bony walls, the etiology on the root surface, and some disease granulomatous tissue surrounding this. Of course, we have to take care to remove the granulomatous tissue to make our intraoperative diagnosis. In this case, I consider at that time non-contained type of defect. I filled with a combination of autogenous bone and freeze-dried mineralized bone graft, and I tried to recreate my ideal parabolic architecture. Of course, because I didn't have any residual buccal walls, I protect this graft with a barrier membrane. This is the only one that was available in 91. So we have been trained to stabilize with a sling suture around the cemental enamel junction. Of course, we know that we had to remove this, and we coronally display the flap in order to get a primary closure. As nicely pointed out by Giorgio before, we want to cover this barrier membrane. We try to fight against their early exposure. So, but also we've been trained that after 6 to 8 weeks, this material had to be removed in order to avoid any disappointment and any complication. So after approximately 2 months, I did a re-entry. I raised a partial dissection flap in order to get access to the barrier membrane. I removed the barrier membrane. At that time, we were very satisfied, very happy to notice some granulation tissue. This is not bone. This is granulation tissue. Is the early phase of the healing process. But at that time, we were so happy to see this regenerated tissue, but we learned a lot out of this healing process. Anyway, after I replaced my flap bed, and fortunately, I got some recession at that time. But because I started with no keratinized tissue, now I wanted to improve the quality of this tissue, because from a clinical point of view, I was quite satisfied about the result. At least I did not have any more the deeper probing depth. I have healthy probing depth, but I don't like to have this lousy tissue. Means I consider this lousy tissue, the alveolar mucosa, on top of some regenerated tissue underneath. So I decided I convinced the patient to make advantage of this newly regenerated tissue, placing on top of this newly regenerated tissue a free gingival graft in order to modify the quality of very thin and I personally consider unstable type of tissue over time. So I had the luxury to raise a partial dissection flap, a partial thickness flap. Of course, in the previously diseased area, I make a small full thickness approach in order to evaluate the healing of this lesion. And considering the previous lesion, how it was before almost 2 years before, as I feel this material at that time, now I'm quite satisfied about the result. Of course, now it looks much better. It looks nice, natural bone. I'm happy about the result. And this is the time that I decide to completely protect this with a free gingival graft. I place my free gingival graft, and we know that this technique, as been previously introduced by Giorgio, is a very stable technique over time. So now we follow this case. We follow not only from a clinical point of view, from and also from a periapical point of view. And so it means that in order to make a long story short, so let me tell you that before guided tissue regeneration, the periodontal approach was only mainly only to treat a space-making type of defect. With the introduction in the literature of the GTR technique, now we can treat also non-space-making type of defect. It means that according to the classification as previously introduced by Giorgio, now we can treat also some more type of challenging type of bony defects, because we have the knowledge now. We have also some experience. Our learning experience now, it's much better than we were very young, and we have, of course, always to consider the learning experience, but now with this technique we can treat a more advanced type of lesion. Okay. So let me share with you the second part of this this presentation, considering which can be the material that we can apply in these clinical cases. So I'd like to cover with you more the bone graft aspect, because we have to have clear in our mind that we have some natural process, as has been previously introduced by Giorgio, that we have the potential in our body to have some good response, considering the osteogenic potential of our body. So we can have some bone formation through some cells that are already in the, for example, in the graft that we are using, and we take this graft. So if you are take, as I mentioned to you before, a big chunk of bone, this chunk of bone has its own living cells, and we can make advantage of this big chunk of bone. But this is not more there are no, I don't think there are no any more periodontists that are doing a big type of harvesting bone techniques now from a different part of the mouth in order to collect these living cells. But this was history, okay? But we have to know the concept, of course. So we consider osteoconduction when we, as a scaffold, we use some material as a scaffold, and we rely on the chemical composition of our scaffold in order to facilitate new bone formation from the existing bone, from the surrounding bone cells of the bony lesion. Ideally, we should have, or we'd like to have, some osteoinduction as a sequence, as a project of our material. So as an osteoinduction means that we initiate osteogenesis through cells that originally are not involved in a bone formation. This concept has been introduced by Urist in the late 70s with the concept when he described the bone morphogenetic proteins. So these bone morphogenetic proteins are able to induce bone formation in a certain part of the body where normally they are not involved in bone forming cells. So this could be our ideal filler material, but not every time it's available, because we have to make a clear classification about this type of filling material, because the market in the bone bank can provide us some mineralized freeze-dried bone allograft, and we have to know that this material get resolved after probably 9 months, and this is going to be replaced by human body very, very slowly. So this material can give us the physicity of the bone graft, is very stable, maintains the space, but we know also that it gets resorption. However, this type of material does not have the potential of the induction material. It does not have bone morphogenetic proteins. However, if we are using a decalcified freeze-dried bone allograft, still from a bone bank, we have the possibility, the luxury to utilize the principle of morphogenic protein. So because during the demineralization with hychloric acid, during the chemical process, that is possible to extrapolate, to have back from the bone matrix, this decalcified, through the decalcified process, we can have back these bone inductive proteins. But however, we have to know very well this type of material, or we have to know the bone bank that it can provide us this type of material. So the best material, in order to make a long story short, as the decalcified freeze-dried bone allograft, because also in the literature it's been reported that this material has the most important histogenic potential. If we compare it to autogenous material that we can collect in our patient directly from the patient mouth, and also it's better than freeze-dried bone allograft. So in order to make a long story short, if I collect some bone from the patient mouth, is fine, is a gold standard. The autogenous bone is good material. However, it doesn't have the autogenous bone, it doesn't have inside the potential to induce bone formation as it has been provided by the calcified freeze-dried bone allograft. And decalcified freeze-dried bone allograft, it seems superior to the mineralized freeze-dried bone allograft. So we can have like the possibility through the bone bank to select, if we decide to get access to the bone banks, to human bone banks, to select the ideal material. And let me share with you this study, because this study has been published by Bowers and co-workers in 1990, and was probably the study that it was a series of 3 studies that it closed completely the debate if it's helpful or not, if it's gold standard or not, if it works or not, because they made such an amount of human histology that will never happen in all the literature in the future. Because at that time, of course, it was possible to make a biopsy, human biopsy, histologic evaluation. It is fine because they compared the healing process of interbony defect treated with the demineralized freeze-dried bone allograft in a non-submerged environment, in a periodontal environment. It's funny, let's pay attention. They use a free graft over the bone graft to retard the epithelium. The concept of the barrier membrane. Biopsy, after 6 months, they collected from 12 patients 32 biopsy. In 12 patients, they inserted 12 patients, they treated with they grafted 32 lesions, and they non-grafted 25 lesions. So they had biopsies out of this patient, and they find out that in the non-grafted area, they found long junction epithelium, no new attachment. In the grafted area, they found a new cementum, new bone, and new periodontal ligament. So histologic evaluation, that is possible to get bone regeneration, human bone generation, histologically reported when we use this type of material. Also, they reported no root resorption and ankylosis that can happen if we are using fresh fresh bone, autologous bone. So this, for the type of study, I think that we don't have to discuss anymore. Of course, not everybody likes this material because it is a human origin, of course. But in order to point it out that this material, at least the free thread bone allograft, has the potential of osteoinduction, and no other material can have the same potential. Okay. So let's switch to amelogenin. I will make only a brief introduction because I know that Giorgio will discuss with you extensively later on. But let me point it out that now is one of the gold standard to periodontal regeneration. After 20 years, now we can consider this an ideal material for bone regeneration. So we have to add this new concept to old concept. And this is available in Europe, in Italy too. However, it's not available for us, the platelet-derived growth factor. It has been reported effective and safe in the treatment of infrabony defects. However, it's not available for us, it means in Italy and in Europe, from what I know. And also an interesting growth factor could be the fibroblast-derived growth factor. It involves angiogenic, osteogenic, it has an osteogenic, angiogenic capability. It seems an ideal type of filling material, but unfortunately is not available right now. So basically the only growth factor available now is amelogenin. So let's consider now the combination of this material, okay? So it's not easy in a short period of time to make everything as clear as possible, as didactic as possible. But we have to consider that when we combine, for example, bone graft and GTR, this technique has to be considered technique sensitive. So we have to have some knowledge. We have to know the material. We have to have our learning experience, learning curve experience, and sometimes it's not easy to handle this material or to get our ideal goal is to have a new regeneration bone, like to rebuild what had been completely lost. However, sometimes we have to be satisfied about a partial fill of the defect, because our expectation, of course, it will be always to get the best, but sometimes we have to be satisfied about a partial fill of the defect. So with the partial fill of the defect, we have two possibilities when we have a partial fill of the defect. So we make a big improvement, but the defect is still present. So we can do in this case a re-entry, to do a small regrafting to improve or to make better the previous result, or to do some orthoresective surgery, as I showed in a previous case, with the combination of crown lengthening on the neighbor teeth if they are needed. Okay, so we can manage this case in a two different way. Of course, our goal is to get a primary the primary objective, to get a restitution ad integrum. And sometimes we are dealing also with some soft tissue deficiency to start with. We have a bony deficiency, we have some soft tissue deficiency, so we have to handle these problems in only one shot. And I will share with this case later on with you on a step-by-step procedure. As in summarizing this case, so we have to perform our knowledge regarding the flap design, like papilla preservation. We have to make an intraoperative diagnosis. In this case, we have two completely different lesions, considering the buccal aspect, considering the palatal aspect. So in this case, it has been treated in both directions with a free connective tissue graft on the buccal, and bone regeneration and barrier membrane with the filling material on the palatal side. In order to try in only only one surgical procedure tried to reach or to solve both problems. Of course, I didn't get a complete coverage of this recession because due to some residual bone loss. However, I was quite satisfied. The patient was quite satisfied about the result and seems very, very stable over time. But I'll show this case later on, step by step, in a very detailed approach later on. Unfortunately, we have to be ready that some cases, they're not doing very well. And I'm laughing because to my student friends, I say that unfortunately, when something is not doing well, we have a beautiful crown lengthening procedure because the failure of the regenerative procedure is an undesired, unexpected, but crown lengthening procedure. So we have to be ready that sometimes if we make a mistake, we have a price to pay. More we prefer to fly in a higher position. When you fall down, it's tough, or it's hard. So we have to be ready to handle this different situation, this unpleasant situation, okay? So once again, of course, our goal is to get a ideal healing, to improve completely, to have restitution ad integrum, but many times it's not possible. In some cases it's not possible. Let's say if this is not possible, we have to be ready to make some adjustment, okay? So we can reduce this deep probing depth, this deep lesion that it was nice as introduced by George, is a contained, beautiful 3-wall contained type of lesion, but it's quite big. So now we have a residual bony walls, a residual residual defect. So in this case, I make advantage of crown lengthening procedure in order to solve this problem. So this means that if something is not ideal from the first surgical procedure, we have to be ready to make some adjustment later on and to improve the stability of this case in the long run. So let me share with you now a step-by-step of the bone grafting. For a question of time is always a problem, okay? I listed over here 14 steps, and some of these I will do it very, very quickly because I'm sure that you are very familiar. So these are the steps that every bone grafting technique has to fulfill. So we have to start with patient selection. So we have to select the patient, especially the patient that has positive attitude towards therapy. So you have to accept that it can be the first surgical procedure and probably some adjustment later on. And the patient has to show us that he has a good level of plaque control. And all these points are very, very important to select the patient. Of course, you have to start with a deep protein death. We have to have bleeding, but especially we have to have clinical attachment loss over time. So we have the possibility, we have the consensus, let's say, to treat this type of lesion. Also, of course, we have to avoid also, last but not the least, during the initial preparation, to avoid excessive on a subgingival instrumentation, because if this is too aggressive, we can reduce the quantity and the length of the residual gingiva, and this can create a problem on the managing of the flap later on. So we collect our data. We have to find that it is a progressive bone loss. We select our surgical procedure that we'll overview later on with you. In this case, was another type of papilla perforation. We use our knowledge and we follow this patient over time, and seems very stable. So now we have the knowledge to treat this type of lesion. Okay, so we follow the step. So the third step is anesthesia. Before the anesthesia, we make a rinse in order to reduce the plaque accumulation. We reduce the bacterial in the mouth. And now, before starting our surgical procedure, we should already look for or to decide in a preoperative diagnosis which type of material we have to use. Because some of this material need to be, for example, harvested, for example, with a forceps. So we need like a bone forceps if we collect intraoral autogenous bone. So we don't don't have to prepare anything before. But if we decide to use, for example, a bone bank type of material, this has been to be prepared in advance. So we open a bottle of mineralized or demineralized freeze-dried bone allograft. We have to make a couple of we have to keep it wet and wash it for 2 times for 10 minutes in saline solution. We have to prepare it in advance. And also we can open or prepare already to have in our surgical tray prepared some bone xenograft in order to be ready and available for the surgical procedure. And also if we are thinking to use a regenerative a barrier membrane, we should prepare the membrane, or at least to open the box to get it ready. Or if we are thinking, because in anterior section, to instead of a barrier membrane to use a connective tissue graft, we have to anticipate to the patient that for the best aesthetic result we should implement a connective tissue harvesting technique. If you think that the connective tissue graft is going to play a better role instead of the collagen membrane for aesthetic reason. Or if you are thinking to use a cellular dermal matrix, we have to prepare it before about 10-15 minutes within a sterile saline solution. So we have to be prepared to use some of this type of material. When we have ready, everything is ready, or we've been previously planned, we start, of course, to plan our surgical procedure. We combine this material, as we'll see later on. So the steps are to clean the root surface. We'll see later on this first. We prepare the material in order to place this material already prepared in ideal condition. Okay, so everything has to be planned in advance. Now we have to decide our flap design. A flap design will be selected based on the type of or the location of the measured depth of the lesion. So my approach is, if I have a very, very deep probing depth on the buccal side, I prefer to perform my incision on the palatal side. So means to prepare to raise a papilla, or to plan a papilla preservation on the palatal side, on the opposite side of the deepest part of the lesion. The opposite is, if I have a very deep lesion on the palatal side, I prefer to place my incision on the buccal side. So we are planning our ideal papilla preservation. We'll discuss this and we'll see this case later on in details. Because this lesion was mainly on the palatal side, I decided to make my incision, my papilla preservation incision, on the buccal side. After raising the flap, it has to be always, in this case, a full thickness flap, as I'm very happy to share my experience with Giorgio, because both we like a partial thickness flap. However, in GTR technique, we have to consider only full thickness flap. So after raising a full thickness flap, we have to remove the granulomas tissue. We can use hand instrument, ultrasonic instruments, long shank. I like very much this long shank Christmas tree shape carbide burr, because it's very, very nicely and fast remove the granulomas tissue inside the bone defects. And I follow this instrumentation with the Eastfield files that is being planned in the historical periodontal therapy to root plane the root surface, but I'm using in this case to remove the deepest part of the granulomatous tissue that is being left in the deepest part of the defect, because in order to get access to the deepest part of the defect, I think this bird, it's too large. So I am using this very small file in order to scrape the bony surface and to remove the residual of the granulomatous tissue in order to get as clean as possible residual bony walls. And after I started to perform my etiological therapy on the root surface, and this our surgical experience can be completely different. We can use hand instrument, rotary instrument, ultrasonic instrument. You can use whatever you want. However, I finish my etiological therapy applying on the root surface tetracycline solution for 3 minutes, and after I wash it out for 30 seconds. So I use cotton pellet impregnated of tetracycline, and I rubbed around the root surface, and I'm asking to this acid material I found some indication in the literature. Okay, so there are completely different type of root decontamination or acid decontamination of the root surface. I'm sure that Giorgio likes some different. Some other clinicians, they have their own ideal material. Anyway, give you my rationale to use this tetracycline solution. First one is an antibiotic. Second is anti-collagenolytic effect. So it means that fights the collagenase during the early healing process, during the early days of the healing process. Also, it has low acidity. It means it's not as powerful as citric acid that is very powerful, very well known, very utilized in the United States. For example, citric acid has a pH 1. So I personally consider very aggressive pH. We have to consider that we will have a blood clot with cells, mesenchymal cells, as pointed out by Giorgio before, coming from our bloodstream, from our blood, from our body. So these mesenchymal cells are living in a basic environment. So the blood is a basic environment. And probably it could be too aggressive to expose these mesenchymal cells that are normally in a basic environment to be exposed in such a very acidic type of environment. So the pH of tetracycline probably is 3 or 4. It's not as aggressive like citric acid, so I prefer this type. The last but not the least, because I'm a old periodontist, I've been exposed in the early 90s and in the early 80s to the Acticide type of principle. Acticide for the old periodontists, they know better than the young periodontists have been exposed to this technique, was very popular in the early 90s, where there were like fibers impregnated by tetracycline have been placed in the sulcus, in the pocket, the liver over there, left over there, and they've been shown that these cords, these fibers, were able to deliver tetracycline antibiotics inside the pocket, and they've been slowly absorbed by the root surface and slowly delivered later on. Unfortunately, this technique disappeared because it was complicated, was not easy to perform, but the concept was not bad. So we have to consider also the majority of the antibiotic delivery into the pockets are based on tetracycline principle, tetracycline application. So I prefer still tetracycline. Keep using tetracycline as a root conditioning component. We can use, after this, I prefer to use intramural penetration in order to expose the residual bony walls to get some bleeding from the underlying medullary cavity. This is more important, if I tell you the truth, in implantology than in osteoregeneration, because we have more marrow cavity available in periodontology than in implantology, of course. But if we need to increase the bleeding, the bone bleeding, intramural penetration can be a possibility. And after we have already selected our graft, we carry the graft. We could be carried with a large amalgam carrier. We pack it we firmly, more or less firmly, considering the quality of this material. And of course, we have, depending on the material, we have to handle in a different way. My choice is to place a little bit of materials, a more small component of material, to have a saline sterile gauze to squeeze it, to absorb the excess of blood or fluid, and to additional, in an incremental way, to fill completely the defect, and after to place the barrier membrane. Before closure, probably we have to perform the most important step. We have to achieve a tension-free flap. We want to coronally advance the flap. We don't want to have any tension action, tension pull, or frenum pull during the healing process. We have to have a completely tension-free flap. So we make a small incision in the periosteum. We interrupt the continuity in the periosteum in order to get the most coronal artery of this flap. They will be able to be completely out of tension, and so will be probably the best way to maintain completely cover the graft for the desired period. The suturing technique have been taken from the GBR steps, let's say from the GBR approach, have been already introduced also in the periodontal literature, and I consider the internal horizontal U-matrix suture as the first-line suturing technique in order to get nice adaptation, connective tissue adaptation of both flaps together. So we have a surface of tissue getting to each other and nourishing to each other. And also I follow this with a simple interrupted suture, because this line of suture needs a second line of suture, so we have to interpose interrupted suture between the horizontal. If I previously made a releasing incision, I prefer to use an anchor suture in order to mesialize and to coronally advance additionally the flap. And so we have to select additional, more or less additional suturing technique considering the type of flap design that we've been utilized. Periodontal dressing most of the time is not necessary because you have a primary intention type of healing. We have to explain to the patient what we have to do. Of course, there are different protocols. In this case, I prefer that you use a sterile gauze to clean the area, not to put the dressing. So the patient, I ask to the patient to avoid the toothbrushing technique, but only with the finger, rubbed around the finger a gauze with chlorhexidine or chlorhexidine rinse to clean with the end like a digital brush at the surface to keep it as clean as possible. I prescribe, according to the literature, a combination of amoxicillin and clavulanic acid for 6 days, 2 grams a day, and painkiller if needed. The suture removal after approximately 2 weeks, and after this start to go back to normal maintenance therapy. I prefer to see the patient in this case once every month for the first 1 year, depending on the material that being utilized. I'm not performing any probing before 6 months. I'm planning to take a periapical X-ray after 6 months. And so this is one of the result in this case that we'll overview together, we'll see later on. And we have to follow carefully this patient in the long run, because it's a chronic, the periodontitis is a chronic disease, so the possibility of recurrence of the reinfection is possible, so it's a possibility. So the advantage of the bone graft is that we, of course, the literature is possible to get regeneration. We want to increase the tooth support, we want to improve function, in some cases also we want to improve the aesthetic, because we try to reposition to get restitutio ad integrum. Of course, this bone graft can be applied in every type of intraosseous type of defects, of course, because all the defects are manageable with, or we can treat these different types with this type of filling material. It seems predictable in the literature, and also there is evidence that these teeth can survive for a long time, also from the literature point of view. However, we have in any case some disadvantage. We have additional treatment time because we have some time to collect some bone from the neighboring area. Also, we have to remove tissue from the patient mouth if you are using autogenous graft, or we have additional expense if you have to buy from a bone bank this material, and of course we have additional post-operative care. You have to follow this patient in a very more accurate way. So, but we have to think if it works for us. So in order to make a long story short, we have been trained to, according to the previous implant therapy. A few years ago, the implant therapy was only a two-stage. In the early 90s, implantology were only two-stage procedure. So with the two-stage procedure, at that time, we had the luxury to do some re-entry procedure. Because if I wanted to evaluate the success of the bone graft, basically I have four possibilities. To make measurements, and this is the easy way, to document with some measurements. We can take repetitive and planned in a very accurate way some radiographic examination, a periapical with a stent, with a reproducible way, or we have to do some quite often re-entry procedure. If it's possible, we can plan it, or very extremely rare is histologic evaluation. So, but was quite easy in the past to make some re-entry during a second stage implant surgery. So this was the bone defect that I got when I was treating this patient from I placed the implant. There was the residual bony walls, the residual bony defect, contained type of defect on the after of this canine. I treated, I inserted my autogenous bone, collected with the bone forceps over here in between the implants. I place it from here, I place it over there. I didn't use any barrier membranes, only filling material. And after 6 months, at that time, I did a re-entry, so I had some improvement. The defect was some residual bone defect was still present, but was some improvement considering the previous lesion. So now we can, during the second stage, if we wanted to make it more flat, we can reduce it to avoid some residual bony defects and to make it perfect. But if we want to test some material, we have the luxury with an implantology approach now to have also some histology, because histology is the most important, the most decisive and most undiscussable type of result. So in this case, this patient has to remove the teeth, some teeth. He has to place some implant. So because he has to do in several steps, we plan to remove this tooth for implant type of regeneration treatment plan, per implant treatment plan. We remove the tooth, we add the extraction socket, we make some changes on the palatal side, we make some pedicle from the palatal side in order to be ready to cover this extraction socket, that we filled the extraction socket with some material. So the extraction socket has been ready now to be filled. We filled the material that we wanted to test for ourselves. So we've used, in this case, we use this xenograph type of material. We fill the defect with this material. We completely covered with a pedicle coming from the palatal area. And we cover completely and we suture. And now we wait, and now it's completely, so the defect is filled, is covered with a pedicle coming from the palatal area, and now the patient went back after placing the other implant in the other area, went back for the healing process, okay? The healing process was uneventful for both implants and for the bone regeneration approach. After 3 months, the healing was uneventful, so we did not have exposure of the implant previously inserted over here, and we do not have any exposure also of the periodontal regenerative material that have been utilized on the distal aspect of this molar. So now we are able to perform our histologic evaluation before placing an additional implant over here, where we had some regeneration. We make a histologic evaluation according to the patient. So we instead of using a 2mm drill, we use a 2mm 3-fine drill in order to collect some bone out of this previously regenerated extraction socket. And of course, he was keeping going with this implant therapy. And now after a while, after a couple of weeks, we had some histologic evaluation. So according to this company, we tried this company because they were telling that these bones start to resorb, and these bones start to be resorbed and be substituted by a human bone. So we have a particle of this bone that get resorption, nicely surrounded by the residual bony walls or the residual bony patient bone, and gets substitution. So this is something that we'd like to have, or at least we confirm what the company was telling us, that this bone is xenograft, is going to resorb after 9 months. It gets substituted by human bone after 9 months. So, in order to finish my first this part, I'd like to get the conclusion, to share with you the conclusion that, of course, we have to start with diagnosis. The diagnosis has to be always stable and very, very strong. We have to have our learning experience curve. We don't have to expect to have an excellent result from the 1 or 2 initial cases, but we have to go slowly, step by step, increasing with an increasing type of difficulties over times. Don't forget the GTR and also GBR are technique sensitive, so it means that they rely on the expertise of the clinician. And also don't forget the old techniques, because the old techniques always have taught us something. So I'd like to share with you a concept that have been, when I was at school, I was a student, a great teacher of mine was telling me that don't forget that when there is a new girl in town, everybody wants to kiss her. So we are fascinated by the new techniques, but you don't have to forget the old technique. You don't have to forget the concept, the basic concept, the old concept that have been based on sound literature, and also from over time type of result. And also, the last but not the least, ask what you're going to do if this lesion is in your mouth. Would like to use a human freeze-dried bone allograft or xenograft or autogenous bone if you are ready to different type of material. Because now we are in an era of ethic environment that you have to have a large amount of material, because for ethic purposes we cannot use in every patient the same material. So we have to be ready to be eclectical, to use in some patients some filling material, in other patients to other filling material. So we have to have the knowledge of this material, and of course in a short period of time it's not possible to overview together, but with Giorgio we try to do our best. Thank you very much.